doses and types of hormones. Now, it's something that confuses a lot of people, including a lot of doctors. Women are all different. Of course, we're all different. We look different. Our bodies work differently, and our responses to hormones work differently. We've known for decades that individualization of doses of hormones is crucially important. And for many of us, we need different doses according to whether we're perimenopausal or menopausal. But it's caused a lot of confusion, as many of you know, to the extent that a lot of people now are really scared about prescribing doses, or if someone needs a higher dose of a patch, for example, then they're refused it. And every day in our clinic, we hear stories from women who are being told that they're not allowed to have a certain dose of hormones, or their doctors are refusing because it's not in their guidelines. So let's unpick it a little bit. I'm going to spend about half the time talking and then about half the time answering questions, because I've had loads of questions, thank you, on my Instagram, and you can put them in the live chat as well, and I'll try and get through as many as I can. So, as many of you know, the best way of having hormones back for our bodies is replacing with the same hormones. So biologically and biochemically, they're exactly the same: estradiol, progesterone, testosterone. The best and most efficient way of having the estradiol is through the skin as a patch or a gel. There is a spray, but in my clinical experience, it doesn't get absorbed very well, so I don't usually prescribe it. So I usually prescribe either patches or the gel, and sometimes I prescribe tablets. We have to be really careful to make the distinction with tablets between estradiol and ethinyl estradiol, or conjugated equine estrogens. So that we have tablets of estradiol, which is a natural body identical estrogen, but we also have tablets of ethinyl estradiol, which is what's in contraception. This is chemically different, and I don't prescribe that. Or we also have available, more in the US, but it is available sometimes here, conjugated equine estrogens, which is a pregnant horse's urine, which I don't prescribe. So then we can have tablet estradiol, or we can have patches, or we can have the gel. When it goes on our skin, it's using the skin as a vehicle of getting the hormone, the estradiol, through the skin into the bloodstream, and then it doesn't get metabolized. It stays as that estradiol into the bloodstream, goes around our body and affects every cell in our bodies to work properly. But the skin is a barrier. We know that the skin is not very good for putting drugs through it, and there's very few medicines that we can prescribe through the skin. Obviously, hormones are one type of medicine. We sometimes give a drug called fentanyl, which is a painkiller through the skin. And you'll all have heard of nicotine replacement, which we can give through the skin as well. But very few things actually work well through the skin. So estradiol is small enough that it penetrates through the skin, but our skin type is very different. And we've known for decades actually that our texture of skin can change, but the thickness of our skin can change, even in our same body. So when they've done studies putting the patches and compared the absorption from the thigh to the bottom to the lower back, there is about a 20-fold difference in absorption. And it's very important that we understand that, because some women might be still experiencing symptoms despite being on a good dose of patch. And it might be as simple as just moving the patch to a different location for the patch to stick well. The estradiol is contained in the glue. So if the patch is not adhering or sticking well to the skin, then it goes without saying really that the estradiol will not penetrate through the skin into the bloodstream adequately. And so we sometimes need to change the type of patch to a different manufacturer, which has a different type of glue. So if you are using patches and you think you're not absorbing well, then have a look at the patch, see if it's bubbling or if it's got any creases in it, because it would suggest that it's not been absorbed well. And actually, when people have an unreliable absorption, it can be really difficult. It can almost take them back to if they were perimenopausal. Because you can imagine if you have some times where it's absorbing a lot and other times when it's absorbing less, if it's the stickiness is changing, then hormone levels can really go up and down, and that can really detrimentally affect some people's mental health. So we have to be really careful when we're looking and reviewing women who are on hormones, when we ask them lots of questions about the patch. It's just to try and work out in our minds, is it sticking? Is it sticking adequately? Is the absorption reliable of the estradiol through the skin? We also know there are other reasons why it's going to alter the absorption through the skin. So, for example, if the skin is warm or cold, the absorption is going to be different. As you know, if we're warm, we often get flushed because our blood vessels go to the surface of the skin to try and cool us down. If the blood vessels are on the surface of the skin and we put something on the skin, it goes without saying that that substance, so the estradiol, will get absorbed easier. If people are cold, you get vasoconstriction. The blood vessels go internally to keep our organs warm. And so then it's further distance, it's harder for the estradiol to get through the skin. If we put the patches or the gel, but especially the patches on an area of our body that is thicker, if we've got more subcutaneous fat, then it's going to be harder to get through into the bloodstream. So there's lots and lots of factors, and we've known that for many, many years. And the same with the gel, actually. When the way the gel is used, when it's applied, the skin acts as a reservoir, and then the gel is slowly, or the estradiol is slowly absorbed through into the bloodstream. And that can really, really vary. And every so often, some people state that the volume actually that is pumped out of the gel can vary, especially if they're coming towards the end of their pump. Or sometimes some of the batch numbers have had quite liquidy, watery gel that floats off the skin and doesn't get absorbed as well. And there are different types of gel that we use in the UK, and every country has got different manufacturers. But we have one type of gel that's in a sachet that's more viscous, it's thicker. And some people find they absorb that better than the gel that's in the pump. It's the same with the testosterone. We usually prescribe that as the gel or the cream, and people really, really vary. Some people like the gel and they find it goes through into the bloodstream very easily, and other people prefer the cream. I was just experimenting a few weeks ago, and my doctor prescribed me the gel of the testosterone for a change. And I spent the whole weekend feeling really tired. I had a lot of muscle and joint pain, and I couldn't remember things at all. And I suddenly thought, oh gosh, this is how I used to be when I was perimenopausal. I bet I'm not absorbing the gel. And in fact, it was floating off my skin. And as soon as I went back to the cream, I started to pick up mentally and feel a lot different. Whereas some people tell me the opposite, that they're not feeling much difference using the testosterone cream. They change to using the gel and they feel so much better. So we can't give up on hormones. I speak to a lot of women who are told by their doctor that because they haven't improved, their symptoms won't be related to hormones. Well, it probably isn't right to say that, because they probably haven't improved because they're not absorbing adequately through the skin, or they're not on the right dose. Some people do need higher doses, and people sometimes get concerned about this licensing of doses. Every medicine that we prescribe has a maximum license dose, and it's just the way the medicine was licensed. It doesn't mean it's off. It's dangerous if we prescribe as an off-label dose. And we know that the studies that were done looking at how what the optimal dose is was actually done on very small numbers of women for a very short period of time. And we've known historically for many years that some people absorb differently to others, and some people need different doses. And many of you know that I personally use higher than a licensed dose, because when I started HRT 9 years ago, I wasn't feeling better. My estradiol blood level was low, so my consultant tried to increase the dose of my estrogen patches, so I was using 2 patches, so 200 micrograms, and then measured the level after a few months, and the level came up, but my symptoms improved. And that was when I was perimenopausal. Fast forward 9 years, I'm sure I'm menopausal now, and my dose requirement has increased. And that happens a lot. In our clinic, it's about 20% of women with time need a higher dose. We're a specialist clinic, so in general population, it will be less than that, but there will still be a number. And we need to be mindful of this, because sometimes I see people who are having awful symptoms, especially affecting their mental health, and I do their blood test, their estradiol level is low, and I increase the dose and they feel dramatically different and better. So we shouldn't be denying hormones because of the way that they're licensed, because this isn't on good science, but we do have good science that some people need different doses than others. The progesterone can be given orally, or it can be given as a suppository, so either rectally or vaginally. But we know that the progesterone should be the proper body identical progesterone. And some women need higher doses than others. And certainly for women with PMDD and postnatal depression, and some people with severe mental health symptoms during perimenopause, actually do a lot better when the dose of the pessary is higher. So some people even need 400 milligrams 2 or 3 times a day as a suppository, rectally or vaginally, as opposed to 100 milligrams orally. So again, we're always optimizing the dose and seeing how people respond. We look at symptoms, we look at side effects, and also we look at future health. We look at future health as well, because we know that if you have adequate absorption, it will reduce inflammation in the body. Lots of people ask about the actual levels, the blood levels, but they're only a guide. In the UK, we tend to have the levels between 250 and 1,000, but some people are better when their level's more like 600. Other people are fine when their level's more like 400. But below sort of 350, 300, 250, if certainly someone is feeling quite well, but their level's only 50, for example, I would consider increasing the dose just to reduce that inflammation, help their bone strength, and help their cardiovascular disease risk, because it's more than just symptom control that we're giving hormones for. It's really important that people are reviewed regularly. We certainly would review someone at least once a year to make sure that their dose is optimized, because often people are on a dose and then they might, like I say, be perimenopausal and have their own hormones being produced, and with time their own hormones will reduce, and therefore their dose might need to increase. The other thing is, many women have skin changes when they're perimenopausal or menopausal before they start taking hormones. The skin can be thinner and drier, and so the dose then that they need might not be very much, just to absorb through the bloodstream. But you can imagine, as the skin texture changes, as there's more subcutaneous tissue, there's more collagen, that the skin becomes thicker, less dry, they might absorb better or worse depending on the skin changes, but that means their dose might need changing, either increasing or reducing. So again, it's really important with time that people are reviewed properly. There's been some discussion whether blood tests are useful or not. They can be useful, but any blood test should be done or assessed in conjunction with a healthcare practitioner. Doing blood tests on their own is often not very useful because it needs to be taken in context. Quite a few people contact me and say, oh, my testosterone level came back really high. My doctor's saying I need to stop it, but I'm feeling really well. Well, actually, for those people, we often repeat the blood test. We might repeat it at a different time of the day or give it a bit longer since the dose was applied, just to make sure it wasn't contaminated in some way or it wasn't a spurious result. And so I wouldn't act on just one blood test. The other thing is, we sometimes do a blood oestrogen level, which is really high, and we think, gosh, what's going on? And then we realize the woman's perimenopausal and she's still producing her own hormones. So then we repeat it and find that it's come down to normal or even low. So that's why looking in clinical context is really, really important. So I'm going to look at some of the questions that I've had today, because I have had loads actually, which is great, but it's sad that so many people have got so many questions. So I'll try and sort of group them together. Someone said, I'm winding down my HRT as I don't have faith anymore. I don't know whether that means faith in HRT or faith in their doctor, but we need to be thinking about the risks of not having hormones if you're winding it down and reducing it. I'm on 100 microgram patches for 5 years. My memory's terrible, constantly hot. What should I do instead? Well, then it would be worth having your estrogen level as a guide and see. And if it's low, it might suggest you need to have either a different dose or a different formulation. So maybe change to the gel, and thinking about whether you need testosterone and progesterone as well. eye migraine and fluctuation estrogen. I notice when I'm low, I have an eye migraine. Well, I've spoken about migraine before, and it can be very common when hormone levels are changing or not high enough. So actually increasing the dose. I often use patches with migraine, so the level is even. Someone's asking about, should I have the estradiol gel morning and night to split it? It varies. If you're only on 2 pumps, I would just do 2 pumps once a day. But if you're on 3 or 4 pumps or more, then I often divide it, because then you don't get like a peak and a trough. So 2 pumps twice a day, for example, can be really good. I've been still having symptoms taking 2 milligrams of oral estradiol. Is this typical? Told that's the highest dose in inverted commas. Some people do need more, and actually 2 milligrams is a fairly low dose. It depends how it's metabolized in the body. I've got some patients who have oral, but then they top up maybe with a gel or a patch, which is fine because it's just a different way of getting it into the body. Bleeding on HRT, tried doubling progesterone, still bleeding. Will lowering estrogen help? Well, it's not just, some people think a certain dose of estrogen needs a certain dose of progesterone. There's no good quality evidence that we need that, because some people have higher doses of estrogen just to get adequately amount absorbed through the skin. Some people actually bleed because their level of estrogen is too low, not always too high, or that they're getting fluctuating amounts of estrogen, which is stimulating the endometrial, the lining of the womb tissue. So I would do an estrogen level in someone like this. I would make sure that there were no causes for the bleeding, so arrange an ultrasound scan, and then adjust the dose of estrogen appropriately. And sometimes giving the progesterone as a pessary, certainly if you're bleeding, you might not want to use it vaginally, but might need to consider having it rectally, and that can really reduce bleeding as well. I'm taking Tibolone. Is there anything better for facial hair? So Tibolone is a very synthetic type of HRT. In fact, it's not really hormones at all, and it has been recommended in the UK that we don't prescribe it because of the risk. There are risks of clotting and stroke, and I always prescribe the hormones separately so you can get better control. So I would see someone who understands better about hormones. Why is my doctor so resistant to testosterone? I don't know, because it's just a natural biologically active hormone, so try and see somebody else. Dosage for a 41-year-old lady to treat with PMDD. Well, I've done some YouTubes, and there's some articles and podcasts about PMDD. Often I start with some progesterone in those days when you're experiencing symptoms, do a testosterone level. Sometimes people need estradiol as well. My doctor wants a small dose until I'm older. Well, that doesn't really make sense, really. Everyone's individual. Some people are fine on low doses. Some people need higher doses. It's really, really varies. I've 61-year-old, no uterus. What about estradiol and progesterone? Yeah, I mean, I've said before, a lot of women who have had a hysterectomy still benefit from taking progesterone as well. Can testosterone be prescribed at night? Yes, it can. You can prescribe it when you like. You can use it when you like, actually. I started estradiol in pills and broke out in hives. Now I'm on Premarin. Is that okay? I mean, everything is individualized. Premarin is pregnant horse's urine. Sometimes when people have hives or an allergic reaction or like mast cell activation, I'll always make sure their testosterone and progesterone are adequately prescribed before thinking about estradiol, and that can actually really make a difference to the way our immune system works. Is there a maximum dose if you don't absorb well? No, there isn't really, but it's all very individualized. There are a couple of things really. If someone's needing a higher dose of estrogen, the first thing is to make sure, do they really need estrogen? Is it an estrogen deficiency problem, or is there something else going on? And that's why it's really important to see a healthcare practitioner. If the level of estradiol is low despite increasing the dose, then it's really thinking about another formulation as well. There's only so much we can keep increasing, and it's really frustrating that we don't have more preparations. We used to have a nasal spray, which was really good. We used to have sublingual estradiol, like under the tongue, which these preparations aren't available. No one's making any new preparations, which is really, really frustrating. These are all quite similar. Can I try progesterone first if I'm perimenopausal? Yes, you can actually. A lot of people, all they need is progesterone. They don't always have to have estrogen. As we get older, do we need less estrogen? It really varies. Some people need less, some people need more. It's making sure you have the right amount for you is the most important thing. I have a thick endometrium, 7 millimeters. Should you take a lower dose of HRT? There's lots of people concerned about their endometrium and endometrial hyperplasia. Hyperplasia means thickening. A lot of people have thickening of the lining of the womb if they're taking hormones or they're producing hormones naturally. That isn't the concern. The concern if there are changes which can turn into cancer eventually. But usually women who take body identical hormones actually have a lower risk of cancer of the lining of the womb than those people that don't take hormones or those that take synthetic hormones. It depends on whether you're bleeding or not. Some people say that if people aren't bleeding, then the thickening of the womb can be greater than if people are bleeding. But it's not just the thickening of the womb, it's what the scan looks like, what other changes are going on. And lots of people have polyps or maybe a fibroid that's causing the bleeding rather than anything else. So that's why you need to really discuss and drill down, what does your scan actually show, and are you having symptoms or not. Some people have contacted me because they've been told they have bleeding, you must stop your HRT and see how you get on. I think that's the most barbaric, cruel thing to do. I know if I stopped my HRT for a few days, I would just not be able to function and I wouldn't be able to work. And I don't see why we should be telling people to do that. If there's a concern about the bleeding, we should investigate people and manage them appropriately, but we shouldn't be stopping a medicine that's having beneficial effects on people. Can you overlap patches? No, I wouldn't, because then you're not getting proper absorption. I did it once by mistake and it wasn't much fun because my symptoms returned. I have a merino coil but feel like I should be getting a bit more body identical progesterone. Yep, you can have body identical progesterone with a merino coil because they're very different. My GP says testosterone can't be prescribed until I have maximum estradiol dose. That's not correct, actually. They're different hormones. So if people need testosterone, they need testosterone regardless of what their estradiol's doing. And so we don't need to wait for one to work to then add in the other one. If someone's testosterone deficient and is struggling, then they should be considered for testosterone. What is the best type of HRT? Is it patches or gel? It really varies. Like, I really don't absorb. The gel just floats off my skin. Different types of gels just don't get absorbed. Other types of patches don't get absorbed with me. So I've only found one patch, but I need to use more than one for it to be absorbed. I might try the estradiol tablets soon and see if they make a difference. Everyone's different, so just be treated as an individual. Don't compare yourself with your friend or get your doctor to compare you with another patient, because it's not going to happen. We're all very different. How can you tell if you're absorbing the correct amount? Well, this is where blood tests can be very useful, it will help us decide if someone is absorbing. If the level is low of estradiol and people are still experiencing symptoms on the patches or gel, then we will consider changing the dose or changing the formulation. So I'm going to answer some of the questions here on this chat. How do you know I'm on the right doses? I'm ready to feel like myself. So again, it's looking at all those three hormones and trying to balance them and then be patient. Sometimes you can have the adequate estrogen that you need, but if you haven't got progesterone and testosterone, you're never going to feel fully balanced. It's important, and it's also important to make sure there aren't other reasons for your symptoms. So, you know, we do blood tests to make sure people haven't got iron deficiency, they haven't got low vitamin D, they haven't got an underactive thyroid gland. All sorts of things can contribute to symptoms, but actually it's looking at all of those hormones together are important. And perimenopause is a hard time because your own hormones are fluctuating a lot. My periods are very irregular and I'm going to start taking progesterone for 2 out of 4 weeks. Sometimes that makes periods a bit more regular. If it doesn't, sometimes I advise people to take the progesterone every evening, and then periods can sometimes then become a bit more regular. Everyone's really different, actually. I'm still getting buzzy, jittery feeling in stage a bit overstimulated in loud crowds. And then it might be worth having your hormone levels done and just assessing to see if you're on the right dose. Greetings from Brussels, thank you. 53, just started my HRT, I have no obvious symptoms. How do I know the dose? Well, then what I would do is wait 3 to 6 months and then have your level done and see what your estradiol level is, and to make sure it's adequately absorbed. So like I say, if it's between 250 and 1,000, then that usually suggests that that's enough for your bones and heart protection. There aren't really good studies on that because our hormone levels can still fluctuate and change, but that's a useful guide really. Why might going from low to moderate dose estradiol cause an increase in muscle and joint pains? Progesterone dose is unchanged. Sometimes people can get short-term side effects when dosages change, but sometimes when symptoms are continuing and we think they're related to low hormones, then it might be that you've had hormones yourself and they've reduced internally. So the external hormones, if you like, need to be increased. And that can be quite common. Or it might be that you're having some testosterone deficiency symptoms. So muscle and joint pains can be very common in people with low testosterone. When you start the patch and put on 6 pounds in 2 months, not fluid retention, with the same diet, how's that possible? Is it the dose, or should you switch the tail? So sometimes it can be due to the estradiol not being absorbed properly, and if people don't have enough or the right dose of estradiol, then their body will still produce estrone, still change its metabolism, put on weight, and so forth. And so a lot of people, when they have the right dose of estradiol, often find that their weight stabilizes or they reduce weight. And testosterone is very important for our metabolism as well as building muscles and reducing fat as well. So a combination of those hormones can be useful for weight. And I would always suggest optimizing hormones and then waiting, looking at your nutrition and exercise before thinking about a GLP-1. Really important. I heard one hormone specialist say that our testosterone messes up our microbiome. Well, it can improve our microbiome actually. Testosterone is very important for our microbiome as well as the other hormones as well. I'm not sure it really messes it up. In my clinical experience, which is very vast, a lot of women with GI symptoms, so gastrointestinal symptoms, irritable bowel type symptoms, reflux, heartburn, really improve when they're using testosterone. And I'm sure some of that's related to the gut microbiome. Full hysterectomy, tried patch, Sandrina, estradiol, now zooming on, brain fog gone, still hot flushes. Am I doing something wrong? On testosterone too. No one does anything wrong. It might just be things need tweaking or changing. Thinking about progesterone despite having a hysterectomy can help with some of those symptoms as well. So it would be worth going back to a doctor who understands hormones to try and balance them properly. Hi from Norway. Oh, I'm going to Norway next week actually, to Oslo, such a great country. On HRT, started with Testosterone 3 months ago, feeling great, brilliant. Testosterone is often the game changer for a lot of people, so it's great that you've been able to get hold of it. I'm using patches and 2 months started having brown spots on my face. So that could be melasma. Now I've done a podcast with Dr. Saj Rajpal about melasma. It can be very common actually. I suffer with melasma myself, and often it's skin damaged skin from the past that can be reactivated, but it is an active condition, and he talks very eloquently about different treatments for melasma. So it's not a reason to stop taking estradiol, but it would be worth thinking about different treatments. So have a listen to the podcast. If you Google podcast Newson melasma, then it will probably come up. I have linear nigra after a while HRT. Does this mean my body is estrogen dominance? No, I mean, linear nigra is similar actually. It's activation of the melanocytes, which is the cells that make our sort of skin to turn brown, if you like, and they can be stimulated by estradiol as well. It's not a bad thing, but it's no one's really estrogen dominant. It would be worth looking at whether you're taking the other hormones, make sure you're on the right dose of estrogen, but some people's skin is just more sensitive to these having hormones back. First 2 months of H2 felt fantastic. For months 3 to 8, bleed every month, feeling like a crazy person, feeling I'm losing myself. Probably because you need your dose altering. We often see that people improve and then they dip again, especially in the perimenopause. So make sure you go back to someone and talk about all 3 hormones. I was told the same, and if I took testosterone, it only convert to estrogen. Is this true? No. So testosterone does get aromatase to estradiol, but only a very small amount actually. And if you're on estradiol, it's less likely to be aromatase because your body's got some estradiol as well. They work very differently. Testosterone works in the body as testosterone. Estradiol works as estradiol, and progesterone is converted to testosterone as well. So it doesn't mean that we can't have testosterone just because we're on estradiol. I've been on HRT for 3 months. 4th month, I've had 2 periods a month. Is that normal? If bleeding can occur the first 3 to 6 months after starting hormones, especially if you're perimenopausal as well. If your bleeding is persistent and heavy, then it's definitely worth being checked out. But it might worth just waiting another few weeks and seeing if it settles. I'm on 4 pumps of estrogen. My GP's contacted me, wants me to reduce the gel due to risk of cancer in the womb. Well, it doesn't make sense actually, because if you're on a dose of estrogen and it's estradiol that works for you and you're on progesterone, your risk of cancer is incredibly low. When you look at the studies for cancer with unopposed estrogen, as in estrogen on its own, that was always the synthetic ethinyl estradiol or the conjugated equine estrogens, not the natural estradiol. So I wouldn't reduce it just for that. I don't know why your doctor's worried, but I would ask him for the evidence, or her for the evidence, and then make a decision yourself. I'm using Sandrina 1.5 milligrams. Can I increase this further? Doctor says I'm on the highest level. Well, that's like I said before. The highest licensed dose is not the same as the highest dose that's needed. The guidelines are very clear that we should be on the lowest effective dose. So some women, their lowest effective dose is a higher dose. Just because we're all different, that's fine. She gave me the alternative of keeping the estrogen the same and increasing the progesterone tablet to 200 milligrams. The risk of cancer is now being shown. There aren't any studies. Some of this has come from guidelines, but if you look at the evidence the guidelines are quoted, they are not robust studies. Sometimes people are suggesting to increase dose of progesterone, but that's to an off-label dose, and there isn't evidence of safety for that. So I think we need to be very individualized. Medicine is a bit of a science, it's a lot of a science and a bit of an art. The art is individualizing care, and you need to see someone who knows the science but is experienced at individualizing care as well. It's not a knee-jerk thing that we should just change doses to one being off-label, higher dose of progesterone, and then not having enough estradiol, and then forgetting about testosterone. Early perimenopause, very heavy bleeding and pain. Can progesterone help? Yes, like I said, it can, and sometimes changing the formulation of the progesterone, so rather than orally as a pessary, can help with bleeding. If bleeding persists, then certainly thinking about a scan. After 1 year of HRT, normal blood level of estradiol 68. That sounds a bit low to me, but I don't know the units. I still have some symptoms. I suggested as I wait. I don't know why you wait. What are you waiting for? If you have symptoms and your estradiol level's low, then I would consider changing the dose. Or if your estradiol level is normal, then think about what else is causing symptoms. Nobody should be suffering. I really feel very strongly that people should not be suffering with symptoms just because their doctor is asking them to wait. Of course, when we change a hormone or we start prescribing it, we have to wait 3 months or so. But if someone's worsening, then I will always help them talk through it and give them that reassurance as well, and sort of guide them through it as well, because it can be very scary when you're experiencing symptoms, especially those affecting your mental health, and you've got no one to talk to or people are dismissing you. Thoughts on Duaviv? Well, Duaviv is a conjugated equine estrogen, and it's got a selective estrogen receptor modulator on it, so it's quite synthetic, to be honest, and it contains pregnant horse's urine. Like, I don't really want pregnant horse's urine in my body. It's not available in the UK, but it is in the US. Maybe for some people it might be helpful, but in my clinical experience, I can really improve most women with just the natural body identical hormones. I wouldn't go to pregnant horse's urine. I'm in surgical menopause, my 30s, taking 75 patches, 100 progesterone, put a lot of weight, constantly bleeding. So I would certainly be thinking about what's the cause of the bleeding. Are you on the right dose? Have your estradiol level done? Think about testosterone, thinking if you need to change the progesterone as well. So certainly there might be a bit of optimizing as well, especially when you've got symptoms. My GP's reduced my dose because of licensing concerns. Well, I think we have to be really careful here, and there is an article on my website about why people are on different doses of hormones. There is no need to just reduce the dose because the GP is concerned, because there's no evidence for this concern. This is based on a lack of evidence, actually, and people sensationalizing and worrying women needlessly. We've known for many, many years, decades in fact, that some women do need higher doses for adequate absorption and symptom control. So a doctor should not be telling someone who's fit and well to just reduce the dose. I've seen people have their dose reduced, and I've seen them have very difficult consequences with horrendous symptoms that have returned. So it can be quite dangerous and negative. There is not good quality evidence saying that higher doses are dangerous, especially when we're giving them to adequately absorb through the skin. So we need to just be better advocates for ourselves as patients and go and see someone else if you're not getting the right help, but it shouldn't be happening. Each time I try testosterone, I get acne and oily skin. And I'm on a 5 alpha reductase dominant. My testosterone is 6. I don't know the doses. Your testosterone level might be slightly higher. We work very closely with Saj Rajpal, and some people, when people have acne on testosterone, he will give them some topical cream like spironolactone to stop the effects of testosterone on their face. So it's worth working in conjunction with a menopause specialist and a dermatologist that understands hormones. I'm on an estradiol patch and 2 pumps daily. I have no ovaries. I'm on 100 Progesterone, getting small benefit of calmness, sleep not great. Would 200 be better? It might be. Some people find increasing the dose helps their sleep. Testosterone can be very beneficial for sleep as well. Being diagnosed with DCIS, told to come off my HRT immediately. Is this the case? I don't think I'd cope. I'm 60-year-old. I'm sorry to hear about DCIS. There isn't any evidence regarding DCIS and hormones, but actually a lot of people think that the hormones will probably be okay. I can't give you individualized advice here. I have done, there is some there is a podcast, or a few podcasts actually, for women who've had breast cancer, although DCIS is not actually breast cancer. And so some people actually will be on testosterone rather than estradiol. And a lot of people continue their HRT knowing that there's very uncertain evidence that that we don't know the benefits or risks when people have had DCIS because the studies haven't been done. But there are risks to your mental health and physical health and future health by not having hormones. So again, it's seeing someone who really understands and goes through and can support you properly. Does 4 pumps of estradiol require 2 Progesterone? No, not necessarily. Like I say, some people have a higher dose just to get enough absorbed through the skin. I've got some patients who are on 50 micrograms of estradiol, and they absorb far more through their skin than someone else who's on 200 micrograms. So it makes no sense to have a higher dose of progesterone in someone who's getting less into their body compared to someone who's getting more in their body just because their doses of estradiol are different. It doesn't actually come from any evidence at all. Thank you so much for doing this. Oh, that's very nice. From India. Great. India, there's a lot of work that needs to be done in India. Right, final question here because I need to go and sort my family out. Can shortness of breath be a symptom of too high? Not always, but sometimes people with asthma, it's the changing levels that can have an effect. I would just be really careful thinking about your other hormones as well, and seeing someone who understands asthma as well, because there are lots of triggers for asthma. If you've got estradiol and you haven't got progesterone, testosterone, it could be an inflammatory allergic reaction that's triggering it as well. Estradiol has dropped from 1,100 to 499. Severe mental health symptoms. I've changed patch to 2 pumps, but think I need more doctors against it. You're probably right. You know, as women, we're not stupid. If you intuitively think that your dose needs changing, you're probably right. If your dose has changed and reduced and your mental health has got worse, then it might be related. So I would certainly consider increasing your dose again and looking after your mental health. If your doctor doesn't want you to do it, go and see another doctor. It's fine to have a second, third, fourth opinion. It's really important that women's hormones are not messed around about by doctors who think that they can be in control of women. Right, I am going to have to go. I'm just seeing if there's anything that I haven't covered at all. Increased risk of stroke on oral estrogen. So with this, the clot and stroke risk is with the synthetic estrogen. So ethinyl estradiol, conjugated equine estrogens, oral estradiol. There isn't any good studies that I found showing there's an increased risk of clot or stroke. If there is, it's incredibly small, and we've got to offset that with benefits. When they look at Bijou, which contains oral estradiol and micronose progesterone, there isn't a risk of clot or stroke, which is very reassuring. So the likelihood is low. I haven't started HRT yet. My GP is worried about my blood test showing a weak positive for APS, which is antiphospholipid syndrome, Hughes syndrome, and are concerned about blood clot if I start HRT. So you can reassure him. We've written some information in conjunction with Thrombosis UK. Even if you have antiphospholipid syndrome, even if you have Hughes syndrome, then you can still take body identical hormones. So you don't need to wait and worry about that. Having estradiol through the skin, natural progesterone, testosterone through the skin, vaginal hormones do not increase your clot risk. So you can safely have those even if you've got a clotting disorder. So I hope that's been helpful. I know it's been a bit longer than usual, but thank you for all your questions. And there's lots of information on my website, drlouisenewson.co.uk. This will be uploaded to a series of YouTubes. There's lots of YouTubes with lots of information. I've got lots more planned, and lots more articles are being uploaded onto my website as well. If you've got ideas of any more content that you want, then contact me through my website or through my social media. And I just want to try and help you as much as possible, because I cannot bear the suffering, the injustice that's occurring to women because doctors don't know enough about hormones. There's a lot we need to change globally, but working together, all of us working together, having a voice, being listened to, is going to make the difference going forwards. So wherever you are, enjoy the rest of your day, evening, night, and see you next week. Thank you.